supporter for all our initiatives. So without further ado, I just wanted to request Professor Azizul Hoque to give his presentations. And please be proactive and ask him questions, and we can learn a lot. Thank you.
Thank you very much for the kind introduction. I like to present this talk mainly geared to the trainee physicians. Definitely some things we need to repeat again and again so that we don't miss common abnormalities that sometimes very crucial in management of the patients. And I have nothing to disclose. As we know that in clinical scenarios, and particularly in acute clinical situations, TUF abnormality poses significant, diagnostic challenge and also management challenge. And because they're very often related to acute clinical situations like STEMI, non-STEMI, Wellen syndrome, life-threatening electrolyte abnormalities like hyperkalemia, hypokalemia, definitely CNS event, different kind of cardiomyopathies like hypertrophic cardiomyopathy, Takotsubo cardiomyopathy, ARVC, arrhythmogenic right ventricular cardiomyopathy, myocarditis. And so we should be very familiar ourselves, and particularly the cardiology MDs and the ER physicians, they should be familiar with those differential diagnoses to help them quickly diagnose and quickly formulate a differential diagnosis. And best way to definitely help the patient is by the management, okay? So as a matter of fact, subtle changes in the TUFs are often the earliest signs of MI, and about 20 to 30% of patients presenting with MI, TUF changes are the only clinical ECG signs. And as you know that after ST depression, TUF inversion is one of the most common presenting ECG signs of non-STEMI. And just as you go along, if you see symmetrical TUF inversions, particularly deep TUF inversions, are after you exclude, if you even exclude other things, they're likely a sign of myocardial ischemia. So you should not miss, at least think about that direction. So our objective here definitely will understand a little bit physiology of ECG TUFs, review of TUF abnormalities, different kind, review of common clinical scenarios that causes changes in TUF morphology, and definitely clinical importance of understanding the differential diagnosis of TUF morphology. Let's start with the case. I'd like to present a case, and I'd like to see if any of the trainee physicians will jump in, discuss this case. A 48-year-old female presented to emergency room with complaint of left-sided chest pain with radiation to the left arm, nausea, diaphoresis, happened about an hour ago, which lasted about 15 minutes. She reported few episodes of chest pain in the past, mainly with emotional stress. She's pain-free now when she arrived to the emergency room. Vital signs are stable, high sensitivity troponin 84, our reference point was 14. And let's look at the ECG. And anybody of the, I'd like to, so anybody of the trainee physicians, please jump in, let them interpret the ECG and what the thing, how they're going to manage the patient. Tushar, can you ask somebody to join? I'd like the trainee physician to jump in. Don't be afraid.
Please, we will be very happy if spontaneously somebody his hand.
Just start discussing this patient. This is in front of you. The patient came in the emergency room and you are handling the patient.
Sir, in that case, can I join?
Yeah, sure. And I wish the trainee physician would do, but yeah, go ahead and discuss, and then we'll go from there, okay?
Okay, this 12-lead ECG with appropriate calibration and speed showing there is T-wave inversion apparent from lead V1, AVL, and from V1 to V4 with some curved ST pattern elevation, likely in V2, V3. So also, so it seems like it's most likely due to ischemia.
No, that is correct. That is correct. That's the reason we're discussing that, because as I mentioned, 20 to 30% TO abnormality is likely due to myocardial ischemia. So let's look at that, and I'm going to discuss that further. So, what's next appropriate step in this patient, right? First of all, the patient had some recurrent chest pain earlier. Chest pain happened about an hour ago when the patient arrived. Patient is chest pain free, and we did see the EKG changes. If it happened to be that you had old EKG, likely it was normal, as for example, so since the patient is chest pain free, whether going to treat her conservatively or do a pharmacologic stress test on this patient to assess for any underlying ischemia, send for urgent emergent left heart catheterization. Certain things you see on the ECG that is very important to note and put in visual memory, those type of changes in the ECG. Or you're thinking about maybe patient have pulmonary embolism, CT angiogram P protocol you want to do, or you want to send for cardiac, we call coronary CCTA, that's available in a lot of places here right now. So, because the reason is here, I put this question very specifically in that way, because what's the best approach for this patient, right? Yes, you're suspecting it is ischemia. Then you go to the criteria by ACC or ESC guidelines for acute coronary syndrome. You need to look at that. Yes, how urgent it is to look into that, whether there's high-risk patient or low-risk patient or medium-risk patient, right? You fall into that criteria. And remember that when you look into the new guidelines also, is there any STEMI equivalent of some patients that you're really worried about, right? As Dr. Chowdhury was just talking about that he had a case not long ago, a few hours ago maybe, like Wellen syndrome, the patient, right? This type of patient really looks like that you have to look at the highest risk patients. You have to quickly sort it out. So this type of ECG, sometimes you can see in Wellen syndrome. I'm going to talk about criteria of the Wellen syndrome. And then it becomes higher priority to take him to the cath lab on an urgent basis, right? Yeah, you could do like either B or E. Yeah, that will both help us to diagnose the patient is ischemic origin or not. But whether you want to do it when a patient, when they have acute coronary syndrome, most likely not. The B or E will not be an appropriate choice, right? And then you go by risk stratification criteria. If it is true Wellen syndrome, if she meets the criteria of Wellen syndrome, she'll need emergent left heart cath. So C would be the right answer for this patient, okay? So let's look at, yeah, go ahead.
Can I, before going to cath, in presence of chest pain and everything you said, if somebody sends tropi in this case and the tropi comes negative, will it be appropriate to send the patient for cath? Especially if you talk about the facilities available in resource constrained areas like Bangladesh.
Yes,
we have to think about the scenario in our context also.
Yes, look at that few things on the clinical presentation, right? The patient has clinical presentation, had chest pain, diaphoresis. That's more like ischemic type of chest pain, clinical presentation, right? And it's like didn't happen one time, it happened a few times and comes on emotional stress. So some sort of angina going on, you cannot rule it out. Second, in Wellens, and you see the TOA abnormality there, okay? And if the patient did not have any clinical syndrome and the TOA abnormality you see like that, yes, then you can do further testing as non-invasive testing to look at that whether there's any ischemic origin or not. Then you can pretty much, if there's no clinical symptoms and you see this type of EKG pattern, may not be it's Wellen syndrome, okay? But if the patient has intermittent chest pain that suggests angina with the classic symptoms that she had, but despite that she's pain-free in the emergency room, it could be early sign, and also troponin may be negative or very minimally positive in this type of patients. So negative troponin does not exclude in the background of these clinical symptoms the patient having acute coronary syndrome. Doesn't if the patient came quickly or the patient reperfused again and the patient didn't occlude totally and did not have true injury, so might not present still with troponin elevation. That is true because for Wellens criteria, you need clinical scenario and pattern of the ECG. Okay, that's also important. Here, in the cases of negative tropi, I would still probably will be high suspicion patient might be having acute coronary syndrome.
So another thing, may I add?
Sure, absolutely. Because you just had a patient today. Okay.
So the issue is that the false, this is Wellens sign in the EKG, biphasic T wave. And there is another type called deep T inversions. Some people call it the Wellens type B. But the issue is that this ischemia is not like a diagonal third branch or OM ischemia. This is a prox LAD. And we know from the Duke database that left main prox LAD, this has significant mortality implications. So these are not just angina. This patient may code, go into VP arrest. So these are very, very emergent situation and not to neglect that because this may cost the life of a patient. Now, the context is everything. If this patient has hypertension and LVH and come to your office, no chest pain, and you can explain this by LVH and Wellens can be associated with that, maybe then you don't need to worry. But if the patient is having chest pain on and off, no LVH, and this type A biphasic T inversion, it is like going out, it is raining, you will get wet.
Yes, absolutely. That's a very important point Dr. Chowdhury has made. But important things that, as I mentioned, that correlation of good clinical scenario, good clinical symptoms, and this type of TOA inversion, correlation with the proximal LAD or a high-grade lesion is 99%. That's a very high correlation, so you do not want to miss it. Okay. All right. Yeah, we did a hard cath.
And that's why another thing that we should not send these patients with aspirin and nitroglycerin and call it a day. That's not going to work. So we need to be.
so my question was, if somebody sends tropi and tropi comes negative, in that case, in that scenario,
still you need to go.
Yes, that's why I'm saying that.
Good point. Troponin will not decide.
Yes,
that is correct.
That's the point I want to make. That for that emergency medical officer or for any fellow who is treating this patient at emergency department, the approach of the physician to the patient and patient attendant is very important in this scenario, because many a times people try to argue why I need to go for emergent cath.
Yeah, this is one of the kind of STEM equivalent high-risk patients. You need to go for emergent cath. That's absolutely right. And we see that patient had very proximal tight LAD disease. Anyway, let's talk about Wellens syndrome. As Dr. Chowdhury mentioned, it's biphasic T wave that you can see like that, initial positive, then negative. That's type A is 25%, and type B is deep T wave inversion, symmetric. That's type B is about 75%. Okay, you can see either one of those. Okay, but mostly 75%, that's more common, the type B. Okay, but as I see that in the ECG, you can see biphasic T wave, and once again to put in visual memory, and you see the deep T wave inversion, okay? But in the context of clinical scenario, I like to mention a few criteria for Wellens syndrome that we have. They may be no ST segment elevation if it does minimally less than 1 millimeter, no ST segment elevation commonly. They do not have precordial Q waves yet, Okay, they do not have precordial Q waves. They have normal ROA progression, but has to have some clinical symptoms, recent history of angina or recurrent angina. But the patient is presenting symptoms could be chest pain free. That doesn't exclude. As I mentioned, and Dr. Asif Tushar mentioned that normal troponin does not exclude that, or it could be mildly elevated. Normal troponin does not exclude that. So that's the criteria of Whelan's syndrome, if you can take a picture of this slide, okay? All right, so what is a normal T wave, how it looks like? As we know that after the QRS, there's a positive deflection, normally slightly asymmetric with the first limb, and then a bit sharp on the slope on the second limb, that normal QRS. Let's look at the physiology, how it happens. So if you look at the action potential curve, as we see that we know that initially when you measure the potential inside the cell, that's normally negative resting potential, about 90 millivolt. I'm talking about the cardiac myocytes here. So when it reaches a threshold, we know the sodium current goes up. That's a zero phase. That makes the, so voltage gated sodium channels offshoot. We see that sodium goes out. Sodium goes in. Okay, that raises the outside charge becoming more positive. And inside charge becomes more positive because sodium goes in. Sodium influx. Sodium influx in. That raises the inside voltage more positive. And then that's the depolarization phase. So that's the sodium related, okay? The influx of sodium from top going inside the cell, from top outside going inside the cell, okay? And then you start repolarization phase. Repolarization phase is then the potassium from inside the cell goes out. Potassium from inside the cell goes out. That causes the drop in potential. That's basically starting the early repolarization phase, okay? And then the potassium goes out and slow voltage calcium ion opens up. That's L-type calcium opens up and it goes in. But they reach kind of plateau stage. Some potassium goes up, similar amount of ion goes in, and they kind of level the voltage about the same inside the cell, okay? So that makes you plateau phase. For a while. Then the voltage activated slow calcium channels blocks off, and then the potassium still goes out. That's what we call IKR or IKS, okay? That's, activated delayed rectifying potassium channels, rapid or slow, either one. They can both, they go out, and that further drops the action potential. And that's the time really the active repolarization happens. The repolarization starts here, but there's a plateau phase, but active repolarization drop in action potential happens here. And we see that coincides with the T wave. Okay? And somebody can ask why we need this plateau phase in cardiac action potential. As you know, it's very unique for cardiac myocytes because you do not see this plateau phase in sinus node or neurocells or even skeletal muscles. Very unique to cardiac action potential. And it's designed evolutionary way. It's very important because you cannot expect the heart just squeeze out the blood in one squeeze. Okay, I imagine cellular level, because all the cells has to coordinate together and make the blood out from the LV to go out. So it will take some time to culminate all the forces. That is the ejection time. That's ejection time. It's called to pump out the blood. So it is very unique for the cardiac myocytes evolutionary way to have this, we call plateau phase. Okay. So here, as we know, the activation of the cardiac myocytes happens from the endocardium to pericardium in this direction. Depolarization, I'm talking about depolarization happens from the endocardium to epicardium. But repolarization happens opposite way from the epicardium to endocardium in this direction, okay? So if you take a section of the myocardium here, just imagine a section of the myocardium, you take that and to analyze that, because it's kind of counter thinking that, okay, the depolarization happens, okay, it should be positive deflection. In repolarization, kind of technically you can think about it should be negative, right? It's opposite to the depolarization, but the T wave is still positive. How it happens? Let's have a dive into that. You can take some few cells here and see how it propagates. Okay, so I'm taking some few cells here, okay? And then I can see that in, like after the P wave resting state, so it's a baseline, isoelectric line. So our inside the cell all are negative and outside the cell all are positive. So there is, and vector of depolarization or repolarization happens like from direction, if there's a gradient in electrical charges, then vector will go that from negative to positive. Okay, so let's see that. Now at looking up depolarization of the ventricle, okay? So here we know the depolarization of the ventricle starts from endocardium to epicardium in that direction, okay? So here the couple of cells got depolarized. So normally in resting condition, inside the cell is a negative charge, but they become depolarized, so they become positive, and the outside becoming negative. Now look at that, 2 cells are depolarized and 3 cells are still in resting phase. So their outside is positive and their outside is negative. So now we created a gradient from this direction to this direction, this direction to this direction. And we know that you're putting the electrode on the epicardial area. So if the vector goes to the direction of the electrode, it will be positive deflection. That's the QRS on depolarization, the positive deflection happens. Okay, that we understand as logical. But when it happens that after they reach the depolarization phase, then we do isoelectric ST segment. That means all cells are depolarized, all cells are inside are positive and outside are negative. When all cells outside are negative, there is no gradient between the cells from endocardium to epicardium, no gradient. That's why it's isoelectric line. Okay. Now we know that there's a property of the myocardium of the heart that epicardial cells repolarizes quickly than endocardial cells. Okay, that's one of the property that they have evolutionary. So what happens when we know that epicardium starts repolarizing in the opposite direction, repolarization. But what happens, let's look at the cellular context. We started repolarization, and repolarization happens quicker in epicardial cells. So what happens, they were positive before when the resting potential was isoelectric, okay? But now the repolarization happens in this way, then inside the cells becoming negative and outside the cells becoming positive, okay? So imagine that 2 cells are positive here, just a couple of cells repolarized already. But in that particular moment, 3 other cells that's closer to the endocardium, they're still outside is negative. They are not repolarized yet, okay? So then there's a gradient, minus, and there's a positive here. So vector is going to go from minus to positive. Still the vector, that particular moment is going towards the lead, okay, towards the leads. That's creating that positive T wave despite its repolarization phase. Okay, so that's the understanding, basic mechanism why in the repolarization phase still we see a positive T wave. Okay. All right, let's look at some normal T waves quickly. And as we talked about, asymmetric little bit. The first segment is a little bit lower slope, and the second segment is a little bit steeper slope. That's the common variant. Sometimes they have some little bit normal variant other way. Slight J point elevation could be broad-based. That's also normal-looking T waves. But if you see tall Q waves, more than 5 millimeter in limb leads and more than 10 millimeter in precordial leads, and definitely more than about 2/3 above of the R wave, then you see peak T wave, tall peak T wave, and they're sometimes narrow-based, short-based, pointed T wave. You need to think about hyperkalemia, one of the thing. Another thing you need to think of, 2 things you need to think of, hyperkalemia, or if it's very early onset of acute ST elevation MI, early onset of acute closure, acute transmural ischemia. Because what is going to happen, hyperacute, we call hyperacute TUFs in that case. But still, in that situation, if you observe the patients on the monitor or in the recording ECG, you might see that this initial segment will slowly rise and cause the ST elevation. Okay, but initial phase could be hyperacute TUFs. You do not want to miss in acute chest pain situation. If you see that, it could be early onset acute transmural ischemia that you do not want to miss. All right, if you look at the evolution of the TUFs after STEMI, as you see, we talked about giant positive TUFs, we call hyperacute TUFs, and you'll see this part is going to go slowly up if the transmural ischemia is continuing, total occlusion of the artery continues. Then you see that ST elevation. This part goes up, causes the ST elevation, and then subacute phase, you might see some ST elevation is still there, and TUF inversion there, starts TUF inversion, and sometimes they can start forming Q waves. That's a subacute phase. A lot of time you might see that patients presenting with this type of ECG had chest pain several hours ago, like 6-7 hours ago. They're coming with the, to a hospital with other associated symptoms. You see that, some sort of biphasic T wave pattern still has some ST elevation, small tiny Q waves. We call subacute MI. But if the patient has active chest pain, you need to consider going to urgent angioplasty in that situation. Okay, and subsequently what happens? The ST elevation goes down, TUF inversion becomes more prominent, Q waves start forming. After, if you don't do anything, then there will be loss of muscles. Then you will see total Q waves, and the TUF inversion slowly is going to be normalized. In certain situation, if the patient had persistent, total loss of muscles and no angioplasty and no thrombolytic therapy were given. So what might happen? You might see, we call persistent ST elevation. That might indicate that the patient might have, we call ventricular aneurysm. Okay. So another thing that you don't want to miss, that I'd definitely like to get a visual memory of that, in acute clinical situation of chest pain, if you see there's ST depression there, and hyperacute tall T waves. There's another sign called De Winter syndrome. That's also very important signs in patients with proximal occlusion of the LAD. Okay, normally you'll see in precordial leads, V2, V3, V4 in that area. So, but why it's an exception? Because normally we used to call upsloping ST elevation is benign. But in this particular case, in acute clinical scenario of chest pain, if you see, despite that upsloping ST changes and tall T waves, that's a De Winter sign. That's acute ACS, and you need to go to the cath lab sooner the better. All right, let's start with a case. A 20-year-old male presented to the emergency room with complaint of productive cough and sharp chest pain. Okay, he visited his primary care physician 3 days ago for upper respiratory flu-like symptoms and was prescribed Z-Pak, Zithromax, azithromycin. He's an athlete, plays college soccer team, no problem. He has history of depression. He also has been on citalopram, okay, antidepressant, okay, but has been stable. So he's still having some, significant coughing going on, chest discomfort going on, and he came to the hospital emergency room, and you see that ECG like that. Okay, so anybody of our trainees can look into the ECG. It's very common, so you should be able to comment on that. But not only looking at the ECG and pattern recognition, why it happens, what to do, and what are the other reasons that we have concern about this patient. Anybody want to participate?
Sir, is there any apparent abnormality in the V1, V2 ST segment?
There is some. You see that V1 to V2, yes, there is some coved TUF, ST pattern, TUF inversion there, and as you rightly noticed is all of the pattern of Brugada syndrome, type 1 Brugada that you do not want to miss. Certain things I'd like to make sure that our trainee physicians put in their visual memory, this type of things. Patient has been, came with coughing, fever, and chest pain, okay? And you need to really ask the patient, and look at that first, what kind of chest pain he has. Most likely he has pleuritic type chest pain. You need to ask that, whether chest pain happening with cough, right? And why it's important, like in this patient management of these patients, let's put that. What's the most likely cause on this patient that contributed to this abnormality of the ECG, right? Whether they started. The reason I put this question, there's some few things to look into that. Whether initiation of azithromycin that caused that. Is an athletic person. He likely had similar symptoms. For athletic people like this type of ECG, whether it's true or not. Use of citalopram, antidepressant agent, and whether he had a fever that caused that, or another thing, he had combination of citalopram and azithromycin. The reason I asked this question, here are a few questions to look into that, okay? We see that he had a Brugada pattern, right? And one of the common thing is that fever can aggravate that, okay? And certain type of medications that are sodium channel inhibitor can aggravate that too, okay? Because they have like 20 to 30%, about 30% of patients, they have sodium channel gene mutation, SCN, I think 5 gene, okay? They have gene mutation, but not most of them, at least 30% of them. But another question I put it here, whether it's due to QT prolongation, okay, happening in this case. Because azithromycin itself can cause some, and particularly in combination with citalopram and azithromycin, they can cause QT prolongation, okay? But QT prolongation is different thing, okay? That can also cause arrhythmia, VT, torsade, can cause cardiac arrest. But here, QT prolongation is not important in this particular patient, because here the most important thing, the patient had fever. Because in Brugada syndrome, fever can aggravate and bring out this pattern of the Brugada, okay? So that's one of the things that we need to look into that, make sure, because if this type of patients, if they have fever, for any kind of reason, they need to aggressively treat the fever, because otherwise it can cause this Brugada pattern and can cause, arrhythmia like VT or VFib, and potentially could cause arrest, okay? So in this case, how we're going to treat the patient? You probably, just need to do a behavioral modification. Patients should be aware of that. Make sure they're well hydrated. Make sure their fever needs to be aggressively treated. If they did not have any passing out or any arrhythmia or anything, you can just treat conservatively this type of patients. But if the same patient came to the emergency room or to your office with history of syncope, passing out spell, and you see this type of ECG, then you need to be very aggressive, because most likely the patient had, VFib or VT, cardiac arrest that potentially that might cause him passing out. So clinical scenario is important, how aggressive you need to be, okay? And we have some patients in our EP department that with Brugada, and they passed out. And sometimes we do some challenge, because if the patient comes out with clinical scenario that potential Brugada but normal looking ECG, there's a niche to do EP study, not always, EP study to bring it out if you have a high suspicion for that, okay? So you can do some prokinamide or flecainide challenge, but it's not always advised to do that. But if you want to do, you need to be equipped with ICD defibrillator in the EP lab. If the patient go to, VFib or VT, you need to make sure that you're ready for that, okay? But, yes.
I just wanted to recognize that Dr. Prosenjit Deb actually did answer the question that this is Brugada type 1.
Okay, yeah, I don't see that right now, but that's great. Yeah. But the question right now, the management issue, a few things I need to talk, because if the patient presented with syncope or something, you need to be aggressive. and then your high likelihood that patient probably had cardiac arrest, and then you need to put an ICD. But that's the first measure in this syncopal patients with Brugada-like symptoms. And then if the patient had recurrent VT, VFib, and having shock with that, then you might proceed with ablation. We call epicardial ablation by the EP. That's a very successful overall. You might proceed with that. That's the management issue, these type of patients, if they have recurrent problem. Despite that, the ICD was placed and having... Tushar, you can say something from EP point of view on that. Okay.
No, sir, as you said, rightly said, it can be done. But for every other department, the question to you and Chowdhury H, sir, if a patient comes to you with a history of fever and this type of Brugada pattern ECG, and after subsidization of fever, the patient's ECG become normal. How, and the patient do not have history of, cannot give positive history of sudden cardiac death in the family. How to address those patients? It's question to you and Chowdhury H, sir. What is your approach to address these patients?
Yes, the question is duly asked because reason is you have to balance the risk and benefits. Okay, if the patient is never had syncope, never had palpitation, we normally do heart monitoring on this patient at least 30 days minimum to see if any in and out of this pattern that you could see. Okay, or then if the patient presents with this type of ECG, and if they have any short-run non-sustained VT or something like that, then it's a high suspicion that you need to probably proceed with that. Otherwise, most patients, we try with lifestyle modification, fever management, and hydration, and also avoiding some medication that could be potential, like sodium channel blocker. Definitely, you should not put them on flecainide, and some sort of anesthetics. If the patient goes to surgery, try to do avoid sodium channel blocker anesthetics. That's the current recommendation, because putting that ICD, preemptively is long-term. Most younger patients has some side effects with that. A lot of complication, infection risk, and other things. That's my understanding. Okay.
Yes. Thank you for your view on that, because we got one patient who went for postdoc in Germany, and during the stay in Germany, he had one episode of fever. Following that, he went to emergency. They had that Brugada pattern ECG and put on ICD. Now the patient came to us for the replacement of the battery, and I asked and searched whether he had any episodes, any family history of sudden cardiac death or anything else. He had nothing, but he's carrying that thing for last 8 years now, and we cannot remove the ICD also. That's the problem we have.
Yeah, I understand, because it's a laser extraction is a huge complication there. That's I'm telling you, there's a risk and balance, and current recommendation right now to watch those patients, and they need to be aware of that, how to do lifestyle changes and fever treatment and these things. But if they have, but we do sometimes monitoring of this patient. If you see like short-run non-sustained VT or other stuffs, then might be a little bit more aggressive. Otherwise, probably not.
So Tushar, this patient did not have cardiac arrest, VFib. This patient did not have sustained VT. This patient did not have any unexplained syncope, and they put an ICD.
Yeah, sir. They were. I think they got a bit aggressive in the management, but the problem happens afterwards.
That is correct.
You cannot put out the ICD. You cannot take out the ICD leads, and the patient is carrying the device for the rest of his life.
Yeah, that is correct. Okay. All right, let's go forward. Thanks for the clarification. This is a very quick understanding type 1, type 2 Brugada. I'm not going to go to detail on that. All right, let's talk about TUF inversion, abnormal TUFs, like how to approach these things, okay? First of all, you need to divide in 2 groups. Hyperacute TUFs, like tall TUFs. Think about, if it is like little bit either acute initial phase of ischemia, like acute initial phase of STEMI, or hyperkalemia. These two things you need to look at that when you see tall T waves. When you see negative depression, T wave inversion, look at that, whether they're biphasic or just T wave inversion. Okay, if it's biphasic, always think about that. If it's a clinical scenario where there's a Wellen syndrome going on, okay, because mind it one situation. If the patient came with STEMI or something, okay, you put a stent. On the next day, you might see a biphasic T wave inversion. That is not Wellen. And patients not having chest pain or something, it's a normal repolarization effect of the myocardium at the territory that you opened up. So that's totally normal, okay? But if the patient is having in the acute scenario, chest pain scenario, biphasic T wave, you need to rule out whether this patient having Wellen syndrome. And definitely if you see T wave inversion, look at that asymmetrical or symmetrical. If it's symmetrical, you need to start thinking about, you need to exclude ischemia. You need to exclude ischemia. That's the approach should be when you approach these type of patients. So let's look at that, few ECGs, like deep T wave inversion, okay? That's a symmetric T wave inversion, okay? Let's look at another one. More deeper, okay, that you need to definitely rule out this type of patient, ischemic etiology, okay? But in some certain cases, look at the slight asymmetric T wave inversion, deep but slight asymmetric T wave inversion. It could be due to LVH, okay, or we call secondary repolarization abnormality. Look at then another patient, this patient with hypertrophic cardiomyopathy, okay? Asymmetric deep T wave inversion, but a lot of LVH there, and particularly most likely this could be apical pattern, okay, that you need to exclude this type of patients. And one thing important point I like to make, if the patient had baseline EKG before, like T wave inversion, and you see reversal, that normalization of the T wave in the setting of acute clinical scenario, like chest pain or something, that has to be acute myocardial ischemia over chronic ischemic injury or something. You need to be very alert at that. It could be early signs of ST elevation, coronary vasospasm, or some sort of acute ischemia. So baseline EKG shows like T wave inversion, it kind of normalized in the setting of chest pain. You cannot exclude ischemia. You have to, think about acute ischemic episode in this type of scenario. Like this ECG, like its baseline ECG look like T wave inversion, and in the setting of chest pain, it's kind of normalized, okay? Normal T waves. You have to exclude this patient for ischemia, okay? So once again, chest pain plus we call pseudo-normalization of T wave, signifying ongoing myocardial ischemia. I'm just putting it 3 times to make sure you understand that, okay? Again, there's a T wave inversion, we call it dynamic T wave inversion or a static T wave inversion. Like if you see a patient comes to the emergency room, they're having chest pain or certain sort of discomfort going on, but you see that T wave inversion is tutoring, it becoming normal, getting abnormal, or different kind of T wave inversion, that we see changes in the axis and morphology of the T wave. In the acute setting, you have to consider, acute coronary syndrome. They are high-risk patients. So we call dynamic ST changes. And it's in the guidelines of ACC or ESC that in the setting of acute chest pain with dynamic ST changes, they are high-risk patients, okay?
But Azizul,
yes.
I beg to differ a little bit, because
okay, go ahead.
Isolated T inversion or
no,
isolated
instead of clinical
T
setting,
changes,
clinical setting.
Yeah, without ST segment is less of an issue. But yes, clinical setting always. But I'm saying when there is a ST segment downsloping or horizontal depression, that actually carries more ischemic issue compared
That
to
is correct.
just, because even in the ischemia, usually the T inversion only, there can be confounding problem and explainable problem like hypokalemia, magnesemia, all that. But symmetric T inversion, then I would agree with you that symmetric T inversions new in a in the correct clinical context is more. But the ST, if that is associated with ST segment depression
is
that
more
actually
important.
is
Absolutely right. Yeah, I think make sure you put in your mind this type of clinical context. Okay, another scenario that you see sometimes on the monitor, you see this type of thing. The patient was placed on certain medications, particularly antipsychotic medication or something, and you see that the T wave, like positive, then negative, then positive and negative, they're very kind of variable. Okay, and look at that. Most important findings: prolonged QT interval. Prolonged QT interval. If the patient's coming with pneumonia, you put them Levaquin and give them like Benadryl or antihistamine. If you see those, then the big problem. This type of patients high risk for sudden cardiac death because they can go to torsade because look at the QT interval is very prolonged. So look at the monitor, the trainee physicians. If you see this type of thing, they're very high risk of patients for torsade. Okay. All right, let's do another case, interesting case. A 41-year-old female admitted to us for progressive short of breath, okay? And this patient has been experiencing short of breath. It's not like acute, going on for last 5 years, okay? But recently it became more progressive, okay? That's the reason she ended up to the hospital. And the ECG showed these things, okay? We see some T wave inversion, a little bit asymmetric, okay? But there's some T wave inversion there. And we see that V1 R wave is higher, RS ratio is higher. There's some right ventricular, overload is going on here that we see that. That's important because then, you have first thing you need to do probably you need to figure it out. It's a chronic, it's not acute. Okay, definitely we don't think that he's not having chest pain at all. She's having mainly short of breath, progressive over the 5 years, but getting recently worse. Okay, and we see on the ECG changes this right ventricular pattern there, RVH pattern, like right ventricular volume overload pattern. We can see that. And the first thing definitely, I'll just share this case. We did an echo. And echo showed right ventricular enlargement and pulmonary pressure elevated. Okay, so there's some explanation on that, the ECG, that the patient has right ventricular overload and pressure volume overload, and it's going on for last 5 years, slowly progressing. An interesting case, the reason being, we did that, CT PE, and we see that, this pulmonary artery is totally stenotic. Okay, the right pulmonary artery is totally stenotic. Okay, so, and interesting enough, the CT, we looked at the aorta also. Patient has inflammatory disease in the subclavian and carotid area, and they are suggestive of inflammation. And the patient was confirmed with Takayasu arteritis. This very interesting case. Okay, and after confirmation, the patient was started on high-dose steroids and also methotrexate. And on top of that, since this artery was occluded, patient received pulmonary artery angioplasty. Okay, and she was brought back 3 months later. Okay, and she had another angiogram, and we see the artery is open. Okay, and initially look at that, right ventricle was enlarged. Okay, we know that coincided with our echocardiogram and ECG finding. Okay, and after that, 3 months later, when she came in, had another CT angio, and the RV is pretty much normalized. And interestingly, look at the ECG. ECG is normalized. Now patient has upright T wave. So sometimes in pulmonary event, like it could happen in acute pulmonary embolism or chronic pulmonary hypertension. And in this case, the arteritis that we had, that's very interesting case that we had. And she was not treated with tumor necrosis factor yet or IL receptor antagonist yet, just methotrexate and steroids. And currently she's on maintenance dose of steroids. And she's doing okay with breathing-wise. Her breathing has significantly improved. So let's do another case, very quick. A 17-year-old competitive basketball player, okay, presented to the emergency room, presented to the front office with significant EKG abnormality. I'm going to show it. His vital signs stable, no symptoms. He has been running a marathon, no problem, and no history of sudden cardiac death in the family and other cardiac disease in the family, and he is totally asymptomatic, okay? And this is ECG, okay? I know our trainees are not participating, but anyway, when you see these ECGs, you need to think about, definitely first thing you need to think about the patient has hypertrophic cardiomyopathy, maybe apical variant or not. This is very kind of classic features of that, okay? And then definitely the first approach is going to be echocardiogram. And we did the echocardiogram. So the echocardiogram doesn't show much thickening of the heart muscle, okay? We see that like 12.5 millimeter here, and we have 11.5 millimeter here. It still doesn't meet the criteria, and the apical area is also similar measurements, okay? So definitely less than 15 millimeter mercury, 15 millimeter length. So he didn't meet the criteria, and he had an MRI done. We didn't see features of hypertrophic cardiomyopathy, okay? And he had genetic test done, and also in the family, his father also had a genetic test done, is gene negative, okay? And then what to do with these patients with deep TF inversion that we have, okay? It still doesn't meet the criteria of hypertrophic cardiomyopathy. We still try to follow these patients in our hypertrophic cardiomyopathy clinic. And interestingly, we advise him not to do any exercise activity about for 6 to 8 weeks, 8 weeks. So we ask him to do deconditioning to prove an hypothesis whether it reverses or not, okay?
Oh, Aziz bhai, I think
yes.
This is a strong chance. This is apical, because in your echo, did you do any contrast?
Yeah, actually, he had an MRI also, okay?
And there is no hypertrophy there?
No. We know we had high suspicion of apical hypertrophy. No hypertrophy there. I'm just mentioning to the begin with, okay? And still we are following these patients, okay? Because with the potential that it might come up in the future, you understand? I had a talk about that last time about apical hypertrophy and how these patients behave a few weeks ago. And a patient didn't, initially we had high suspicion of apical hypertrophy cardiomyopathy, okay? But he did not have hypertrophy there, and we did not have this, like delayed relaxation in that area by the MRI features that we call it thickening problem. He did not have that. So, and then he was advised from our hypertrophic cardiomyopathy clinic not to do any exercise like 8 weeks, and he was not very happy. But I just showing this case, interesting case, and his EKG normalized, okay? And we did extensive study, genetic and family, genetics and all these things. But then we let him exercise again, okay, with the understanding that he's still doing okay. And interestingly enough, after a few months back, 6 months back, he had again TOV abnormality, okay? So I just wanted to show this case to understand that in athletic people, sometimes they have some TOV abnormality that could be reversed when they do deconditioning, but that's not the reason we can prohibit them to exercise. And we're still following these patients to assess for the future, to see whether they develop any features of hypertrophic cardiomyopathy. Okay. So we're still following these patients.
I think we need to explain a little bit better because if it is an athlete's heart, it may be dilated, but there is no diastology change.
That is correct, yes.
Yeah, if it is a hypertrophic heart, then there is change in diastology. And as you said, that it is the same spectrum, familial hypertrophic cardiomyopathy. It starts, and then you can follow, and it will evolve into that as the patient grows older. But in this case, it is load dependent and exercise, and you have nicely shown that no change in diastology, LV function and property is normal, and this is reversible. In apical hypertrophic cardiomyopathy, this will not be reversible. And it comes in the board how to differentiate athlete's heart from the hypertrophic cardiomyopathy. It's a very beautiful case.
Now, that's interesting because we're still following this patient. Unfortunately, about 20-30% patient will evolve in several years, maybe hypertrophic cardiomyopathy features like apical. We're still following this case, but it's most likely athletic heart because as Dr. Ahsan mentioned, that since diastolic property is normal and there's no erratic, myocardial fibrils developed there that we see in apical or any kind of hypertrophic cardiomyopathy, and then they have repolarization abnormality that is permanent. That's not going to go away. Okay. Here when this volume status, stress-induced volume load is decreased, then the repolarization could be normalized. But when a patient exercises again, we see the similar features, but still kind of benign features that we are not to be too worried, but still we need to monitor this patient for long term. As I mentioned, 20 to 30% patients develop in the long term those features.
And it is a challenge when if this person is a competitive sports
athlete,
because
yes,
if it is a casual amateur versus a competitive sports, then I usually ask few other cardiologists to be involved. So it is a collecting decision, or not just my license only.
That's good. It's a shared decision making. You're right on that. Okay, we call it shared decision making. Let's quickly recap those. Okay, TUF inversion, definitely need to look first. If it's symmetric deep TUF inversion, look first myocardial ischemia. Or what are the other causes? Could be hypokalemia, secondary repolarization due to like LVH, RVH, WPW pattern, and could be acute pulmonary embolism. Cerebral TUFs, we call it raised intracranial pressure after a stroke. Memory TUFs after V-paced or ventricular tachycardia, those type of situation, the repolarization still can be, not restored, even the rhythm is restored by that time. And definitely, when you exclude all of those, there's another entity we need to remember that we call juvenile TUF pattern that we see normally, TUF inversion in younger adolescents, and particularly like African American here, but it could be some other Caribbean countries also see this pattern. They kind of persist more than adolescents' lives, but if they persist more than 40 years of age, you need to still think about whether these patients having any ischemic changes in that area. Okay, before you put a juvenile TUF pattern, you need to exclude other causes first. So we talked about these things. I'm just quickly look at that, like LVH with repolarization pattern. You can see them TUF inversion, okay, because you can see the significant LVH there. You can see like another situation we call arrhythmogenic right ventricular cardiomyopathy. You can see right bundle morphology like incomplete or complete, and you see that epsilon wave. There's an epsilon wave, and then TUF inversion with right ventricular abnormality that we also need to exclude. You can see in acute pulmonary embolism, though these features S1, Q3, T3, you will see only 20 to 25% of patients, not always. But when you see right ventricular strain, too much pressure or something, definitely your management needs to be aggressive on those patients. As we call cerebral TUF, when you have like any stroke, acute stroke, particularly subarachnoid hemorrhage, you can see deep TUF inversion. You can see that, but it has to be with the clinical context. You need to make the decision. The patient came with the stroke symptoms. Definitely need to think about most likely it is due to stroke. But if patient is coming with chest pain, unless there's a delayed MI having blood clot in the inside of the apex and that causes the stroke, then it confuses everything. But normally, even the acute setting of chest pain or something, then you need to think about ischemia. If the patient came with stroke, weakness, speech problem or something, think about the cerebral TUFs. It happens when there's significant surge of catecholamines, and that causes bit-to-bit resting of the heart impaired, and that causes repolarization to just restore the repolarization of the heart is getting impaired because of significant adrenaline surge that causes this TUF inversion. Okay, and we talked about that. And memory TUFs happens after ventricular pacing, as we mentioned, intermittent pre-excitation, transient bundle branch morphology that can do that, paroxysmal VT that can do that. And definitely, as for example, we could clearly demonstrate that after being paced a little bit, and you can see that after pacing is done, and you can see that TUF abnormality still becomes negative TUF, that we call memory TUF, because by the time you paced and there is some interruption of normal repolarization pattern, it kind of memorizes that our myocardial cells, it takes time to get normalized. Sometimes it can stay like few hours, could be week or 2 weeks sometimes, but mostly a few hours and a few days, then it reverses, okay? So once again, clinical presentation, okay? With this acute coronary syndrome, pulmonary embolism, cerebral accident, you need to make sure you have differential diagnosis in the case of TUF inversion. Second, you need to think about the presence or absence of ST elevation. Is it a part of STEMI? Okay, you need to think about that. TOF morphology, it's a deep TOF inversion, biphasic TOF inversion, acute clinical settings. You need to make sure it's not Whelan syndrome, okay? And definitely symmetric deep TOF inversion, and particularly when it's associated with ST depression, has to be ischemia, okay? And definitely the associated ECG signs we talked about. If there's a pathologic Q waves, ST depression, you have to think about acute coronary syndrome. If there's voltage criteria for LVH, RVH, bundle morphology, think about secondary repolarization. Think about if there's a long QT interval and prominent U wave in the same ECG, think about hypokalemia. It may present or not present, but you still need to think about, you need to check the electrolytes to make sure hypokalemia is not present. Okay, and memory TFs, as I mentioned to you, ventricular pacing, VT, intermittent bundle branch, or WPW, that can cause the memory T waves. So once you exclude everything, then you can look at that, like if there's persistent T wave, like similar like that, like V1, V2, V3, excluded everything, and then you might put a diagnosis persistent juvenile T wave pattern. But if still they're above 40, you need to do at least ischemic workup to make sure, like stress test or pharmacologic or CCTA, make sure there's nothing wrong with their coronaries. I think I'll stop here, Tushar.
Yes, sir. You have correctly stopped your presentation just at 1 hour. We have almost all the discussions regarding TF changes. A very explainable, entertaining, and well-explained session today. So the reason we choose this topic is that TF inversion perhaps is the most common findings that we get in day-to-day ECG. And almost all the person who has TF inversion gets anti-ischemic therapy throughout the country. So this presentation was meant to correct that idea that not all TF inversion needs ischemic management. Before ischemic management, we need to rule out many other things. And before going to further, I'd like to request Professor Azizul Hoque sir and Professor Chowdhury H sir, how long do you continue nitroglycerin or nitrates in ischemic patients? Because many a times we see patient getting nitrates, once started, it is not stopped throughout their lifetime.
So let me tell you this: nitroglycerin is in heart disease, and nitroglycerin, it is more attractive in Bollywood movie than real. Then there is no science behind it. So let's get it clear. In Bollywood movie, they'll make this nitroglycerin, and then the hero is saving the heroine's dad, that kind of thing. Nitroglycerin has no mortality benefits, zero. And nitroglycerin can be problematic in inferior MI. And then with the hypotension, nitroglycerin in anterior MI can be problem because it can drop blood pressure. If you drop BP, you are in trouble in acute MI. That's number one. Second thing is, it may be of benefit if the blood pressure is too high and there is pulmonary edema, then you may have venodilation and preload, then nitroglycerin may have this issue. In a stable CAD, nitroglycerin is good only for symptomatic management. So there is nothing else nitroglycerin does. There is no need for keeping nitroglycerin for years after years because আপনার ইসিজিতে দোষ আছে। ইসিজিতে দোষ আছে, এটা কোনো diagnosis না. This is basically trash. So we need to be very careful that we do not tell our patients for years after years taking medicine because we gave them in connotation and a disease that doesn't exist. And Aziz Bhai was brilliant that to differentiate that what is the T inversion that is suggestive. And I'm very careful to say he was not definitive. Even Aziz Bhai was not asking that T inversion is equates ischemia. it raises
Absolutely not. Yeah.
suspicion. It raises suspicion for ischemia. But stretching that to ischemia and CAD and then start treatment for not only the nitroglycerin, then aspirin and Plavix and all this, it is really disheartening. I get so depressed when I see this kind of malpractice. And Tushar, you are absolutely right. But we cannot, I mean, at least we have 35 people in this room. At least we try to learn and we try to make changes as much as we can.
No, and my question was to both of you, sir. How long do you prescribe in an ischemic patient the nitrates? How long?
Let me talk to a few points. Okay.
So I gave you one answer before Aizbhai. I am really passionate about it. Nitroglycerin is symptomatic. Nitroglycerin is symptomatic. If the patient has symptoms, it continues. If no symptoms, stop and then take it off. Remember, each day, nitroglycerin can cause, it is well known, tachyphylaxis.
Yes.
So it is very important that you don't escalate the dose and don't give a break. Then it will be tachyphylaxis. This is classic pharmacology thing in nitroglycerin, that it can cause tachyphylaxis.
Yes. Let me make some few comments. It's very important that Dr. Ahsan, made that points that nitroglycerin actually has no role, almost no role, unless the patient is symptomatic with true angina. Okay, there's some small, because tachyphylaxis is a major issue. Second, they have a small niche in particular patients, like if the patient has Prince metal angina, like vasospasm, the patient has endovascular, dysfunction. Sometimes those two patients, we keep them on long-term antibiotic, nitrate, but this should be long-acting nitrate, but only this few cases. Another few cases that I would like to recall, that as for example, you did angiogram, you did angioplasty, everything, the patient has some diffuse disease, you cannot get to there, non-revascularizable, either by angioplasty or surgery, and the patient is walking, having some chest pain, doing some activity, having some chest pain, still that's for symptom improvement. Those are few cases only nitroglycerin is recommended. Otherwise, just TOF inversion should not be. It's not a case. If you see a TOF inversion, your suspicion is there, you need to find out whether the ischemic cause is there. You need to remove the ischemic cause if you can open it up with a stent or certain surgery or something you do. That's your goal, not for chronic treatment. Okay, chronic treatment has no role of nitroglycerin. That's the thing I'd also like to point out. In certain other case, long-acting nitrate is important in heart failure treatment, but that's totally different scenario. Okay, only vasomotor, vasospastic angina, or like Prince metal angina that you call about, or non-vascularizable disease that that potentially could cause that. We add on top of that beta blocker and normal therapy, anti-ischemic regimen, we can add long-acting nitrate to see whether they have symptom improvement. Still for symptom improvement, not for randomly chronic treatment. Absolutely not.
Sir, thank you very much. It's almost close to 11 p.m. Right at Dhaka. And from the ECG study group, we want to congratulate you for this excellent presentation. And we also like to thank our participants who stayed with us for late at night. Thank you all. And there will be an ECG fiesta occurring at Bangladesh Medical College premises, and we will circulate the presentation there. Thank you all for staying with us. Good night. And
Thank you.
We'll again meet on 8th August.
Thank you, everybody.
Thank you.